Okay. Is everyone able to see my screen?
Yeah, yes, thanks.
Okay, perfect. So I'll be talking today about healthcare in Cyprus. They recently switched over to what's essentially a single payer system, and we'll talk more about that in a second. But first off, I do want to include a little disclaimer that Cyprus, as it is split into two parts, basically the northern part, which is the Turkish Cypriot part, and the southern part, which is the Greek Cypriot, which is how it originally was. I'll only be talking about Yesi, which covers the Greek Cypriot part, because that's the only part that's nationally recognized by any other European nation and any other nation. They won't really recognize Northern Cyprus. So just for the sake of the presentation, we're only referring to these parts in pink and then the parts in green as well. So the outline today, we'll talk a little bit about Cyprus. I know it's a small country, so not everyone knows what it is. And then we'll transition to YESI, which is what we call the National Healthcare System. So the naming of it is a little bit interesting. It stands for, in Greek, Γενικό Σύστημα Υγείας, which, if you translate the physical letters, gives you GESY, although interchangeably you could hear it as GHS, which is General Healthcare System. So you'll hear it both ways, and both are pertaining to the same concept. Then we'll go into the healthcare infrastructure and then end with critiques and where they're taking it in the future. So first off, starting out about Cyprus, it is, as I mentioned, a very small country. So it has a population of just over 1 million with a GDP of $28.4 billion. And per capita, the income is about 26,000. So like I said, it's very small, not a huge budget that we're working with. And so it puts us kind of in between US states if we're looking at sizing. It's an island nation in the East Mediterranean and is geographically part of West Asia, but culturally and politically it's linked to Southeastern Europe, and it's in the EU and it's considered part of Europe. So it has a very big aging population, and there's little population growth and increasing immigration, as you can see in the pyramid. A lot of older people are staying, and then they'll have kids, and the kids will move out and go to England for university usually, and then move or stay there. This is their burden of disease, so their life expectancy is pretty good for the EU and for in general. It's 82.3 years, and the EU average is 80.6, so we're above that. Their infant mortality rate is 8.36 per 1,000 live births, and then they do have among the highest smoking rates in the EU. So lung cancer is the leading cause of cancer mortality, and then they also have the general circulatory diseases, cancer, and diabetes, which we see with most countries. And then this little chart is comparing the Cypriot use to EU. So as you can see, tobacco and smoking is a higher average than most of the EU. So the history of healthcare in Cyprus before they switched to YESI was that they were the only EU country to not have some sort of national healthcare. Everything was going through third party, and mainly what would happen is that the jobs would pay for the health insurance. So healthcare costs were around 5 to 6% of Cyprus's total GDP. And it was all, like I said, private insurance, either through your job or you pay for it and you get your own private insurance. They had greater than 50% of medical costs for out-of-pocket costs, which were the highest in the EU. And private insurance spanned anywhere from 100 to 400 euros per month for a family just to be covered. And then on top of that, you still have your visits and co-payments and everything. So it wasn't really an effective system. It was rated one of the worst ones before they changed it. So now we'll talk about the transition to YESI. And so what is it? It's meant to be a free healthcare system. Obviously, when I say free, everyone pays into it. So it's a relative term, and everyone contributes based on the percentage of their income. So it's a federal health insurance scheme, and private insurers still operate, but they're very limited and cater usually to internationally based Cypriots. So for example, a lot of my family has private insurance on top of YESI, but that's because a lot of my cousins study in England or in Denmark, in which case YESI doesn't cover those costs. It would only cover the costs within Cyprus. So technically it's a multi-payer system, but what we say is YESI is the 500-pound gorilla, and they are also trying to slowly edge out of the private insurance to the case of travel or student insurance mainly. So non-GHS, which is that global health system, physicians are allowed, but again, they're limited, and usually they're pushed off because everyone's already enrolled in YESI. So then there's not really a need to have your private insurance. 85% of Cypriot doctors, 75% of hospital beds, and 100% of labs and pharmacies are all joined in YESI. And so how it works is essentially every Cypriot citizen or every person in Cyprus is enrolled in YESI, but the doctors can choose if they want to enroll in it or if they want to go through their private route. There are 5 principles that YESI states that they follow, which include universal coverage, equal and equitable treatment, comprehensive package of healthcare services, freedom of choice of providers, and then social reciprocity, which is like support and care. So rolling out YESI was a little complicated. We had the fun little thing called COVID that happened during it. So they first launched the law in 2017, and that's when they announced that YESI was about to happen. So they called the General Healthcare System Amending Law because as I'll mention later, there's a lot of changes that they've done to it so far, and there's a lot of changes to be had. It is a very new system, so with that, they're still figuring out what works and what doesn't. The first stage began June 1st, 2019, and that's where they covered everything for primary care. In this case, I thought it was really interesting because their primary care actually includes a lot more than the US primary care would. They consider x-rays, blood work, and ultrasounds, as well as your normal visits to your PCP, all part of primary care, so all of that was covered. Stage 2 was planned to launch June 1st, 2020, so they were expecting the rollout to be only a year. So that would be secondary care, which is what they see as mainly vaccines because it's all preventative, and then tertiary would be hospital and surgical procedures. Obviously, COVID happened in 2020, and so the secondary care was interrupted, but because they saw so many hospital visits and such a need for the tertiary care to be covered, they were still able to launch out tertiary care so it mainly affected just that secondary care. And so this is a list of everything that's covered under YESI. This is, again, an expanding list. I think I saw it expand a little bit within the past year. So they added some things such as palliative care, which we see down here. But basically, it's a very comprehensive list of everything that they're covering. And another huge thing is all of the pharmaceuticals are mainly covered. So who can you see? When a person first enrolls with YESI, they register with a general practitioner. And so at first you got to choose who you enrolled with, and then they changed it because everyone was enrolling with the doctors that they wanted. So they randomly assigned it, and then they said, okay, but if you find your doctor is available and your doctor has space to take you, then you can switch. So it still gives you a choice in who you see, but it was just made so then it was a little even for the playing field, and then doctors weren't having that huge of a burden with keeping all of their randomly assigned patients and their current patients. To see a specialist, the general practitioner will have to refer you to the specialist. Again, with this, they'll refer you to a specific specialist, but you can go see another specialist in that field. The only thing is that you can't see the specialist without no referral at all. So you still need a referral from the GP to see a specialist. He'll refer you to a specific doctor, but it doesn't always have to be through that doctor. Because of this, private doctors are still available because people, of course, chose to stay with their doctors and maybe their doctors didn't enroll in YESI, but it's slowly becoming more and more rare and more edged out just because, again, everyone's already paying for the national healthcare system. It's working pretty well, so why pay double for your healthcare? So just a couple of highlights here. For personal doctors, they focus that people have the right to choose and change their doctors. So that's what I said, where you are originally enrolled with one doctor, but you can change who your general practitioner is. With pharmacies, they have the same prescription distributed monthly for 6 months. And then nurses, midwives, and allied health services require referrals, specific diagnosis, and they only have a max number of visits per year. So this is something that would probably be looking at expanding, hopefully, just so then people aren't as limited. Dentists have the same role as the doctors. Basically, you get the right to choose and change your dentist. And then palliative care and rehab covers both inpatient and outpatient, which is really nice. So you're not limited to just one. As for the financing, it's based on general income and other taxes on all sectors of society. So here's a breakdown of the percentages. And again, they changed it as the phases came. So they didn't want to do just a cold cut, nothing to like 4% is what they're taking. So this just shows how they broke it down for different contributors. So you see your employees, your employers, the state, and then if you're self-employed, income earners, all of that. The interesting thing is that they still take it out of your pension. So if you are retired and you're earning pension, they'll still take it out of that. So that concept of, oh, why am I paying for old people when old people aren't paying for me isn't really applicable, because the old people in this case are paying. So there's global budgeting for each healthcare service sector, and that's publicly available. And we'll talk a little bit more about how that's changed since the rollout. And in 2019, their healthcare spending was $1,996. I believe that was per capita. And this is just comparing the market size. So as we've said before, the percent of GDP is now 7%. It was interesting because that went up from when they were originally at 5 to 6 before in their old healthcare system, although the US spend is about 17.8%. So it's interesting seeing that change. And then this just breaks down how much is spent on inpatient services, how much is spent on pharmaceuticals, and how much is spent on outpatient. And so all of this is from 2019. So this is following the first rollout of ESC, but not the second one, not after it fully covered the tertiary and secondary cares. So co-payments, again, are far less compared to the US system. It'll show here a breakdown of what you would relatively expect to pay for each visit. So even something as low as a pharmaceutical product is €1. But again, mainly that's because they want some sort of payment, but then it's essentially free if you think about it that way. So max copays for each year are 75 to €150, depending on what your income is. And then you'll usually pay €25 for a non-referral visit. And then for pharmaceuticals, if you're choosing the more expensive drug, you'll cover the difference. So they'll pay up to what the cheapest drug would be, and then you'll just pay the difference, which is a lot nicer compared to the US system, where we see it's very all or nothing. It's either you take the generic that's available at a relatively low cost, or you'll just pay the $300, $400 if you want the more expensive drug. So who is covered? Mainly, we'll talk about Cypriot citizens and their dependents, just because that's most of who's living there. However, it'll also cover other EU citizens and their dependents if they choose to enroll in there. It'll also include non-EU citizens with permanent residence or working status, as well as refugees or those of protective status, and special cases granted exceptions by the federal insurer. So for non-EU citizens with permanent residence or working status, they actually have an aliens and immigration law, which gives them the right to equal treatment by insurance. And in this case, the insurance would be ESC. In cases of refugees, they have their own refugees law that gives these rights to those granted status and their dependents. And I thought it was really interesting because I looked at ESC's YouTube page, which they actually have, and I didn't expect them to, and they actually they talk about what the enrollment includes, but they also talk about how to enroll, and they have it for both English and Greek speakers. So they really seem like they try to include as many people as possible in their system. Another thing to note is that people without income, such as the unemployed, children, students, soldiers, and others, also have equal access to free ESC medical services. You just have to enroll them, but they are covered by that. So as for the healthcare infrastructure, they are slightly above the EU average on how many doctors per their 1,000 population. So they have 4 doctors per 1,000, and then 6 nurses per 1,000, which is actually very low. And they have, for GHS hospitals, which is the global health system hospitals, they'll have 5 district hospitals, 1 pediatric and gynecological hospital, 3 rural hospitals, 38 health centers, and 230 sub-centers with touring medical teams. And so this is an example of the Nicosia General Hospital, which is a public hospital. And as you can see, it looks like it's very well maintained. It's very pretty still. So they don't have maybe the linoleum floors that we do here, but it's still nice, it's still clean, and it's still well kept for being a public hospital. And so the digital health infrastructure, they have portals for the beneficiary and the provider. They have essentially one universal electronic health record within ESC. So if you see any doctor within ESC, the doctors can see your history from another ESC doctor. The only thing that this doesn't include is doctors outside of the system. So if doctors are not enrolled with ESC, that's where it causes a bit of an issue, but they are working on fixing that. They stated that keeping records was one of the major issues that needed to be tackled in healthcare design. And so they're trying that with the Cyprus-made blockchain, and that's what they're testing, where it's basically some sort of key tag similar to what France has, where you can have all of your health information on one thing, and it's universal with every provider in Cyprus. And they're also working on doing that for all of the EU as well. So again, because people in the EU travel between countries so much, it would just make more sense. And then distribution of technologies is not disclosed, so they don't really talk about where they choose what medical devices go where, but it is a critique that we'll talk about later. And so for medical education, they have 6-year programs. You do 2 years preclinical, 3 years clinical, and 1 intern year. And the average tuition is $17,600 in US dollars for the, I believe that is for the entire term, but I might be incorrect. I'll have to double check. They have 6 medical schools, so 3 of them are public and 3 of them are private. And the private schools are targeted toward international medical students. As an example of this is on this next slide, such as St. George's University of London. So there's no university hospitals in Cyprus. It's too small for that. And the people seeking medical education usually will go abroad to do it and then return to Cyprus. Most doctors there have either studied in England or in the US, and then they'll go back to Cyprus to practice and have their own practice and follow through with their careers. But so they have the framework complete, but it was delayed due to significant opposition from physician unions for the university hospitals. And there was a concern for imposition on jobs for practicing physicians, sort of what we see a little bit in the US, where it's the attending and, all the residents are the ones who spend a lot of time with the patients. In Europe, there's huge on-patient interaction culturally, which is why sort of that idea of having less time with the patient isn't really as ideal to them. They have clinical training in public hospitals. Again, they go abroad for residency. And then advocates say that university hospitals would improve patient care, raise and equalize quality of preclinical training, attract academics and specialists, and decrease emigration of young educated Cypriots, which is what we see where a lot of them go out to London or the US to study and then come back. But some of them, again, don't come back. So there's significant physician shortage, especially in primary care, which they tried to bypass with coming out with ESC. They let a lot of specialist doctors re-register. So specialist doctors, if they got their degree before a certain year, were allowed to re-register as a primary care doctor. So that sort of tried to help alleviate the primary care shortage. And they also have more recruitment efforts in physicians, sort of trying to get more of the doctors from Greece and England to come back, which again is why we see the St. George's University of London. This is in Cyprus, but they teach the St. George's curriculum. So the original reimbursement and cost control providers were paid on a unit price system, which is basically a fancy term for fee for service. There was a goal to prevent doctors from doing unnecessary procedures without proper indication and abusing the system. So it's kind of hard to do in a unit price system, but that's what they are trying to cut out. There were set fees according to diagnostic related system using expected costs per diagnosis and demographic. So the ESC website explains it as the DRGs, which is those diagnostics related groups, contribute to the strengthening of healthy competition between hospitals, a fact that is expected to become the basis for the increase of quality of healthcare services for the benefit of all beneficiaries. So this kind of goes against that point of people saying that there won't be much competition, because what they try to do is with the unit price system originally and saying if you see more people and you treat more people or more cases, then that drives you to be a better hospital and you'll get more funding from us to keep feeding into your hospital and keep being a better hospital. So that was the original goal. Did it work? A little bit, but not fully. So personal doctors were still paid through per capita, and the comprehensive cost control methods were undetermined, and that's where they wanted to focus on in the future, but they didn't really know what else to do. For personal doctors, they had fees based on the age and the needs of each beneficiary, which sort of caused them to want to exclude certain demographics. And then they had intended to reduce unnecessary spending. So all of the services were paid for on a monthly basis. So the doctors mainly just got paid at the end of the month or at the beginning of the month, depending on their practice. And then copays were paid upon the receipt of service. But again, we saw those copays were usually €1. At most, I think I've seen someone pay 5 or 10, but those copays aren't really much for you to make a living wage. So usually it'll be through that compensation through the government. The HIO, which is the health insurance organization, which basically runs and makes sure all of ESC is working correctly, maxes the admin costs at 5%. Unfortunately, the past couple of years, we've been above 5%, but that's expected when you roll out a new system and you're trying to fix so much all at once. And so they're actively trying to lower it. And that's one of their biggest targets for the future, is to lower those admin costs and keep them maxed at 5%. So as I mentioned, they've changed the reimbursement. I thought it was interesting. I went to double check my slides and I saw there was a July 2023 update. So they changed it first in June 1st, 2022. They reformulated it so that physicians are no longer exclusively paid by the number of patients. So it was no longer fully fee for service. And instead it was a basis of quality criteria and indicators. These include home visits, on-call care, and then in terms of personal doctors like GPs, it was the issue of referrals. And in terms of pediatricians, they also checked if they were present at birth, and if they were, that would go towards their compensation. They then further updated in July 2023, and this was mainly based towards the hospitals. And so they added a new assessment of patient satisfaction, and their rating counts towards their compensation up to 10 points. So it goes to a sort of point-based system. They didn't release, or at least not that I could find, the exact points to how much the compensation is. And I think it's relative based on how many points each hospital accumulates, and then they'll probably get a percentage of the healthcare budget based off of that. But there's an evaluation of the hospitals based on a questionnaire, and it'll impact the compensation for hospitals by the end of each year. So it's done on a yearly basis, and it considers the type of admission and number of senior citizens. So they get additional points if they have 5 to 10% of patients with comorbidities, sort of because those patients have extra costs. They also sort of incentivize those hospitals to take care of those people, but also give them with more resources to take care of them. And more points if the percentage of elderly patients is greater than 10%. So again, as we saw, Cyprus is a growing population, and that's sort of why they want to make sure that the elderly people are being taken care of. And the more elderly patients you have, they're not really a money-making place, but again, the hospitals aren't money-making entities in Cyprus. So it's sort of just seeing that if you have more older people, that's going to be more costly than what you're getting out of it or what's going into the healthcare system. So you're going to want to increase the compensation for the hospitals. So then for critiques and future directions, there were quite a couple critiques of ESC. The doctor over here is Dr. Marino Soteriou, and he originally vocalized a lot of concerns about ESC prior to his rollout. I'm waiting to hear back on him for a follow-up on how he thinks the system works. We've been in contact a little bit, but aligning schedules along with the time difference has been quite interesting. The first thing that he critiqued was the lack of transparency, and you'll hear this from a lot of Cypriot citizens. Before the rollout happened, not many knew how it would work, or they didn't even see any studies that were being referred to. So there were a lot of studies that they were referencing on how it would help doctors and how it would help patients, but they never released them, which caused a lot of people to be skeptical. They distributed a leaflet about ESC, but it was not easy to understand to the common Cypriot. It used a lot of more pointed language and it left people not knowing how the system works and what to expect from the system. There were also complaints that some people abuse the system by asking for excess referrals or tests that aren't necessary. And so the HIO tried to clamp down by tightening procedures and setting limits to number of medical actions that someone is eligible for. But ultimately, the reality of a free system is that people will naturally try to game it. And so while they can try and cut down on those people gaming it, they don't want to do so to the point that it affects the patient's health or the patient's care if they actually do need those referrals or tests. Another huge point was that representation in the HIO includes unions, patients, and people from ESC. So the HIO is, again, the insurance organization that deals with the money, and ESC is the actual people rolling out the system, but it doesn't include physicians. And so a lot of physicians were mad because if they were supposed to implement it, shouldn't they be able to express expert opinion during decision-making process? This one is a very valid point. And I think they've tried to start listening to the feedback from the physicians, but I'm not entirely sure on an update on this. This is where I wanted to talk to Dr. Soteriou. Another big part was repaying technology concerns. So as we saw, Cyprus has a relatively small GDP. We are a relatively small country. And so that means that they would need 30 years to repay certain technology. And the issue with that is that new technology comes out every 3 to 5 years. So they're trying to understand how to invest in new technology while only limiting it to 6% of the GDP, which is something, again, that they're still trying to figure out, still trying to work around, but that comes with being a smaller and relatively poorer country. There were some arguments about delays in appointments, and it was a valid point because there are many doctors that can be seen. People still prefer their doctor. And so if they had their doctor prior to the rollout of YESI, and then they registered with their doctor and their doctor got a bunch more people registered just naturally through the YESI system, it would cause delays in appointments. However, that does not mean that there is not a doctor you can see. There are still doctors that you can see if you needed, a last minute appointment. You could call and be like, who is a doctor that's registered with YESI that has an appointment for tomorrow because I have this emergency thing that I need to be seen for. And you can still see that doctor. It's just the concern about seeing their particular doctor. And then obviously it needs reform. So there are checks and controls in the system that are somewhat inadequate, and they do need to be fixed before the deficit increases more. We saw a higher deficit than we would expect or than we would hope for. But again, any new system will need reforms. They need to keep changing things to allow hospitals to run more sustainably. And that's something that they're just trying to figure out the flow of. It's been realistically 4 years since the start of the rollout, but really less than 3 years since the rollout fully took place. So there's a lot to be updating, especially since the hospitals are a big reform, like a big area of concern for the reforms. And those are what came into rollout in a very trying time and a very difficult time money-wise, because there were a lot of costs that they weren't expecting. And then there is, of course, the consideration that new systems will always need reform, as I've said. And my main question when people ask me that is, would we rather keep fighting the old problems that are only getting worse, or we start solving new problems that are somewhat attainable? So looking into the future of YESI and where they want to take it, they want to expand the coverage for innovative and other previously uncovered drugs. So that's, again, a key point of putting more money into the system and understanding how we can better manage the money that's in the system. They also want measures to safeguard patients from exploitation by fake service providers. And this is common anytime that a healthcare system changes, because there are people, saying, oh, register with YESI and blah, 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 or like register with this new insurance company, that they, again, if they don't understand how YESI fully works, then they could, especially the older population of Cyprus, fall in for these things and give their information. The reforms for physician pay based on quality of care. And again, that's what we started seeing based on the number of referrals and the number of doctors at the pediatricians at the baby's birth. But again, referrals isn't really the easiest way to check quality of care, because someone could just refer to a bunch of other specialists. There's increase in training and recruitment for high demand specialists. So again, that goes into the physician shortage in general. And new legislation and accreditation requirements to ensure quality of care for patients, especially those in long-term care, sort of going along with those other subcategories of YESI, those other subcategories of care that's covered by YESI that isn't as exactly primary care, secondary care, or tertiary care, such as palliative and home nurses and all of that. And then, of course, exploration of further public expansion. So this video I'm going to show you now is what people knew about YESI. This was 2 weeks before it was supposed to roll out, and what they knew about it and what they thought of it. So I'll go ahead and play it and let me know if the sound doesn't work.
Στην 1η του Μάρτη να αρχίσουμε να πληρώνουμε όλοι για το YESI. Εσείς ξέρετε γιατί πράγματα θα πληρώνουμε?
Γιατί ήδη ξέρουσι, δεν ξέρουσι. Πιστεύω ότι θα πληρώνουμε για ένα σχέδιο το οποίο 99,99% θα αποτύχει. Είναι ένα άχρηστο σχέδιο.
So in 2 weeks we're all going to start paying for the National Health Scheme.
Okay.
Do you know much about it?
Never heard of it.
Θα πληρώνουμε γενικά είδος φόρου για τις υπηρεσίες που να προσφέρει το YESI.
Ξέρετε πώς ακριβώς είναι να δουλεύει?
Δεν ξέρω. Να τα μάθουμε βέβαια τα όλα.
μας αρέσκει. Προτιμούμε τα νοσοκομεία μας, τους γιατρούς μας, να πληρώνουμε να βρω τα φάρμακα μας.
Αφού ήταν δωρεάν, δηλαδή είναι πιο δωρεάν από ό,τι τώρα είναι η ιδέα.
Αν είναι πιο δωρεάν, ακόμα δεν μας ενημερώσαν για να ξέρουμε. Ακούμε στην τηλεόραση, αλλά δεν ενημερώσαν μας. Ακόμα τσακώνονται εκεί να μπουν και να μπουν.
Κάθε πολίτης θα έχει το δικό του παθολόγο. Ο οποίος παθολόγος θα τον παραπέμπει όπου χρειάζεται. Θα έχει αποκοπή, φαντάζομαι, 1,7 βάσει των μισθών του, δηλαδή συντάξεις, μισθοί, ξέρω εγώ. Στρατιώτες, μαθητές, άνεργοι θα είναι δωρεάν.
Ξέρετε πολλά καλά, είστε στην αρκετά πιο ενημερωμένους και τους περισσότερους.
Είχα δει ένα leaflet του ΓΕΣΥ πριν περίπου 20 μέρες.
Αν είχα διαβάσει ένα φυλάδιο που είχα βγάλει, ξέρω κάποιος μου το έστελνε ένας φίλος, αλλά ο τρόπος που τα έγραφε, το πώς να λειτουργήσει, δεν ήταν αρκετά κατανοητό νομίζω στο ευρύ κοινό ακριβώς πώς να λειτουργά. Αν θα μπουν όλοι οι γιατροί μέσα, αν θα μπουν οι γιατροί, αν έχουν επιλογή, δεν έχουν.
Ο ασθενής έχει το δικαίωμα να αλλάσει τον παθολόγο του ή οποιοδήποτε τον παραβέρσουσει. Δεν γραφτούν οι δικοί μου γιατροί, που εγώ πάω χρόνια κοντά τους διάφορων ειδικοτήτων, έτσι με πολλά ασθενείς, αλλά λέω τώρα. Και η οικογένεια μου να πρέπει να πληρώσω έξτρα να πάω να πληρώνω το γιατρό και λέω άλλο γιατρό.
Υποτίθεται ότι ένας γιατρός να πιάνει, να συμπληρώσει 2.000 άτομα ή 200 άτομα. Τούτο είναι συγχυστικό, δηλαδή για όλους φίξει τιμή, που ξέρω ότι δεν θα για όλους φίξει τιμή.
Ένα δεδαλώδες σχέδιο, το οποίο θα μπλεχτούν και 500 μονοστέφανοι που το μόνο που μπορούν να κάνουν είναι να τρώσουν και εμείς θα πληρώνουμε διπλά.
Νομίζετε να πετύχει?
Όχι.
Θα πετύχει, ναι. 100%. Θα πετύχει. Πολλοί λες είναι όχι για διάφορους λόγους, αλλά εγώ πιστεύω ότι θα πετύχει.
Νομίζετε μπορεί να μην πετύχει?
Ναι, νομίζω να μην πετύχει, διότι ορισμένοι το πολεμούν.
Γιατροί?
Έτσι φαίνεται. Εσύ και άλλα συμφέροντα, οπωσδήποτε.
Νομίζω να πετύχει. Διότι θέλει το κόσμο όλος.
So as you can see, a lot of people had very negative thoughts on it. They didn't really know much about it, but there was one person who knew pretty well on what it covered and how it was going to work. And he was one of the 2 people only who said that he thinks it'll work out. So realistically, how did it end up going? So 82% of people in Cyprus are happy with YESI's services and how the system works. 80% stated that there was an improved quality of life. And there was a 99% renewal rate by doctors in 2022. So doctors who decided to stay in the system from 2022 to 2023, only 3 of those doctors left, and all of those were because they were moving out of the country. And so it wasn't an issue with the actual healthcare system itself. So in theory, it seems like a great healthcare system. There are more changes to come, and we've seen there are some parts where it is inefficient or where the cost gets a little too pricey. But overall, it's a great system, and there's a lot of potential given that it's only realistically 3 years in the making. So these are just a couple comments that I found of people who actually live in Cyprus and have thought of and what they think of the system. So this person says, I think ESC is fantastic and a massive achievement for Cyprus. It works very well and reminds me of the UK NHS before Tories ruined it with austerity. Honestly, only good things to say about ESC. Another person talks about their severe endometriosis, saying that ESC allows them to afford it. And then comments such as thank God for it. My wife is on chronic medication for an autoimmune disease. So we see all of this where this person actually lost their job, which in the old health insurance system means that they would not be insured anymore. They wouldn't be able to cover their wife's medication, but because of ESC, it was okay with a layoff, and that wasn't another added concern that they had on top of everything else. This person says we should protect it, improve it, and ensure its long-term viability. Biggest achievement of the previous government. And talks about the NHS again. Of course, to me, the comment that spoke to most was this one that says, if we compare the health system in the USA, for example, yes, he seems perfection. So that will be the end of the presentation. There is my email. There's Sammy's email. He did a lot of the financials. So if you have any questions about the financials, you can go ahead and reach out to him. But feel free to shoot me an email if you have any other questions, or we can take some questions now as well. Let's start with Dr. Metz.
You just hit that last slide. Can you save that information in the chat?
Yes, let me send. I can send all of that in the chat.
Maria, that was an incredibly informative, succinct summary. I don't think I understand American healthcare as well as I do Cypriot healthcare right now. Congratulations on putting together a very effective presentation. This kind of begs the question, who was the brilliant Cypriot who got the idea that the whole nation should move to single payer and then sold it to enough legislators and interest groups that it happened?
So funny thing about that actually is in the internship, we talked a lot about who designed the Taiwanese system, and we, Dr. Dockhart mentioned Taiwan quite a bit. It's actually the same person who did that system that helped design the Cypriot system, and they tried to base it off of the NHS and get rid of all of those bad stuff in it. So it was a couple of people that went into it, and then as for the actual government, when I showed that last comment that said one of the greatest achievements of the past government, they actually had pretty bad reviews, or people were very controversial around the government before that, and they released it and it shot up their ratings right before the election. So part of it might have been sort of an elective scheme, but it was, I think, because they had the worst health insurance in Europe, it sort of also helps push you towards wanting to have a better healthcare system. But it is the person who originally designed the Taiwanese system who helped design the Cypriot one as well.
Thank you. One of those originals lives in Oregon and teaches in Oregon now, Dr. Chun-Wei Chi, who was part of the team of American economists who were recruited by Taiwan to completely revamp their healthcare system, much like Cyprus did. Thank you.
I can take Betty Dumas.
Hi, thank you for that. That was excellent, really. And I'd love to get a recording of it as well, because you got so much information in there. I was like, wow. But I wanted to ask you, because I really wasn't that clear about how they structure reimbursement for the physicians. You had mentioned something fee for service, but it almost sounded more like an HMO or an ACO. So I was kind of curious. And actually, I believe the people that structured the Taiwanese healthcare program actually is more like an HMO. So kind of curious.
Yeah, so they originally wanted to do the fee for service based on that unit price. They realized pretty early on that that doesn't really cover any of the actual quality of healthcare. And so that's why they started adding in those measures, such as the hospitals getting reimbursement based on how patients say their experience was and based on the demographics that they see. And similar things with the doctors, it started being on metrics of like, what should the doctors be crossing off? Okay, if you're a pediatrician, then you should be seeing the birth of the child. So if you're there, that gives you more compensation. If you are a primary care doctor, you should be seeing people and referring them. You shouldn't just see them and write them off. So that's going to give you more compensation. So that's something that, again, they're actively trying to work and actively trying to change. It's hard because there are some unions in the hospitals for the doctors that are quite still running the hospitals, but not officially running the hospitals. So that's sort of the main thing that they're trying to figure out now, is working better with the doctors on the compensation. But that's sort of why they switched out of the fee for service pretty fast, was because they actually cared about the quality of what is the patient seeing. And I think they're focusing a lot more on the patients than they are, for lack of better terms, they're focusing a lot more on the patients than the physicians in terms of how is the patient care. And then we can worry on, is the physician really getting, their full, getting their full payment, because obviously they're still paying them, but that's not the biggest concern. The biggest concern is, are the patients being cared for? And then after that, we can see how much the doctors are being cared for based on how much the patients are happy with it, if that makes sense.
Thank you.
Of course. Michael Pan.
Yes, that was an excellent presentation, good video. I liked how how the people who being interviewed, they provided their anecdotal experience, which is wonderful because it really speaks volume because we need that anecdotal experience speak to to majority of Americans who are skeptical about single payer Medicare for all. And I'm just curious, so for that video, how you thought about as a group, as a collective, or as individuals, how you thought about maybe like providing this video to members of Congress? Because I think it really needs, I think members of Congress need to see this video themselves to really understand how people in Cyprus initially disapprove of universal healthcare, right? And over time, they became more supportive. So how do you think you could distribute that video to members of Congress? You know, based on the interview, based on the video that we saw. That's number one. And two is how do we transplant how do we transplant people's experience overseas into America? Because Americans, you know, although the support for America is growing, but it's nowhere near like a majority to say, hey, that they're fully on board, that we can fully transplant it.
Right. As for the members of Congress comment, I haven't looked into that, but that's something I think would be really interesting to do because that video spoke to me so much because what they said in that video was vastly different from what I was seeing online. But all of the online comments and anecdotal experiences were quite a few years after ESC had already taken place. So it was within the past year. So I think it would be really interesting to show it because I think it does say a really strong point. I mean, when you have only one person or two people who say, yeah, I think it'll work, and everyone else is saying 100% it won't work. There's no way that it'll work. And those are the people who are actually benefiting from it and love the system now. And all of their doctors are signed up. I think that says a lot. And I think that that will probably be some of our strongest ammunition is showing examples like that are not only so recent, but also it comes from people who are in a similar healthcare system to us. And it's sort of exactly the switch that we want to make. So I think that would speak volumes. And then, sorry, do you mind repeating your second question?
Oh, yeah, second question. Yeah, second question I asked. Yeah, so second question I ask is, how do we like translate the people's experience in Cyprus about their healthcare system and trying to cater to American values of, you know, of fairness, individualism, fairness,
Want anything else? I'm ready to go. I'm getting ready.
individual liberty, and pursuit of happiness.
So I think the best way to explain it would probably be start by approaching it on a state-by-state basis. But in terms of American values, I think it fits in very easily if you pull on the satisfaction part. I mean, how can you quote unquote follow in pursuit of happiness if you're physically not able to get up because you have endometriosis and you can't afford the medications or anything like that? In terms of fairness, we see that they pull out of even the pension from they pull out from the pension that they give to the elderly. So again, that leads into fairness. Maybe it's not quote unquote equality because it's not equal amount from everyone, but it is fair because it's the equal percentage based on how much you make. I mean, if someone's not making that much, they're not expected to pay as much, but they're still paying something. And I think that's the same way of why students are covered for free is because they're expected to, it's sort of investing in your youth, you know, they're expected to, you know, just focus on your schooling. We'll take care of the health. That won't ever be an issue. Just go and get your schooling and feedback into the system. So I think I think it's a mindset in the US that sort of needs to be changed in all of these buzzwords, but not actually following through with what they mean, if that makes sense. But I think there is a way that we can spin it as long as we focus on specific stories and specifics to sort of tick off all of those buzzwords that they want to hear.
Yeah. And because I understand that doctors in America, yes, they want Medicare. I know majority of doctors in America want Medicare for all, but they still want to maintain the fee-for-service payment model because they've seen what happened after when Obamacare was passed regarding the fee for value, which didn't do doctors like any good. My slight concern is that we get into Medicare for all hypothetically, right? And then we switch from fee for service to fee for value. And I'm concerned that it might make the doctors' dissatisfaction even worse.
So Michael, we have 4 people waiting to talk.
Oh, go ahead. Sorry.
So just a quick answer to that is that they didn't fully eliminate fee for service. It's just fee for service is not the full compensation. So it does combine both. William Vonston, I got some of your questions in chat. Did you want to verbalize any of them, or were there specific ones you wanted
Maria,
to?
first of all, thank you very much. The presentation was just spectacular. So first of all, I'm interested in the alignment of mental health alongside the alignment of physical health. I'm interested in the issue of the presence of poverty in the population and the way in which the universal single payer system is impacting poverty in general. I'm interested in how the caregivers' attitudes are changing in relationship to their identification with the people that they're caring for, that they're not becoming bureaucratized, they're not becoming alienated, they're not becoming brutalized, but they're actually becoming more loving and caring in relationship to how they're providing services and how that system is influencing that attitude.
Right. I think the biggest thing to consider when we're considering Cyprus is also considering the social aspect of it. So in terms of mental health, there's a lot for the mental health that's beyond just the physical health. So they do fully cover visits to counselors and everything like that. Although there's a much stronger support system family-wise and socially wise. So church, for example, isn't just a place of religion. It's sort of where you see the people that you're expected to see every week and you see your neighbor there and you catch up or anything like that. So while they do cover mental health visits, I think there's also less of a mental health issue because of the social aspect of how the country works. Again, it's very small, but that also does mean that you know your neighbors a lot. And then as for poverty, I'm looking it up. Looks like their percentages of poverty has been going down, but poverty is something that Cyprus has always been trying to keep relatively low. They don't really allow beggars on the street, which is like what we would see here. You're really, if you are begging, usually you'll be taken away and put into an actual place for homeless people or for unemployed. So they take good care of them, and they actually include jobs where they can to help those who are unemployed. So they have at gas stations, people in Cyprus don't actually pump their own gas. They have attendants there who will pump your gas for you. And then you tip them like €1 or two, but that's usually jobs from people who used to be homeless. And that's a way to start getting them back into the system. Do you mind repeating? I know I answered 2 of them, but you had a couple.
So one aspect of that is, do the people feel that they own the delivery system as opposed to here where we don't own our delivery system? And secondly, has the system altered the attitudes, the subjective attitudes, the caring attitudes of the caregivers towards the population in any way?
From what I've seen anecdotally, because I shadowed a couple of doctors in Cyprus, it didn't seem like it. It seemed very much, again, before it used to be very neighborly, you just go see your friend who happens to be a doctor. And it seems like the same thing. I shadowed a cardiologist, and he had patients text him and be like, hey, do you have availability today? I'm feeling a little off. And he would just take them, they choose, their lifestyle is pretty nice as a doctor. And so I think that because they were able to keep that helps them stay positive with the system. So doctors make, I think it's roughly 60K. Of course, cost of living is a lot cheaper there, but it's not the most extravagant wage, but it's still a pretty good wage for living in Cyprus. So it's sort of that they also enjoy their lifestyle and they were able to keep their lifestyle. It didn't really alter too much in the hospitals, as I mentioned, because they're still somewhat unionized and they sort of still run this hospital. It helps the doctors. I'm not entirely sure about people feeling like they own the system, so I feel like I would need to follow up with you on that if you don't mind sending me an email. But I can definitely ask, because I have a lot of family there, so I can see how they feel in terms of their healthcare. I know they're really happy with it, but I don't know about the owning the system part of it. And Betty?
Hi. So thank you very much. Great presentation again. I'm sorry Shami couldn't be here with us. When you gave the presentation to the group, to the internship this summer, you had a slide where you compared the culture in Cyprus versus the United States. Do you remember the slide I'm talking about? and features of the culture that you said were specifically different that made them more likely to be willing to have a system like this compared to ours. Can you talk a little bit about that?
I believe we mentioned it. I don't know if we had a full slide of it, but we did talk about it in terms of COVID, of like wanting to be respectful of your neighbors. And it's a huge, more neighborly, I'll do a favor for you and I don't expect anything back type of thing, which is why I think you also don't see as many people complaining about, oh, I'm paying for all these dead weights. I mean, you saw some people in the video who were like kind of concerned about it and concerned of people gaming the system, but it's not really one of those huge points that they're like, oh, why am I paying for my grandma? Or why am I paying for someone else's grandma? Because it's sort of that system of, if you're my friend's grandma, you're everyone's grandma type of, I would say, type of culture there. And so I think it's sort of seen as, wow, why didn't we do this sooner? Because we should have been taking care of everyone sooner instead of only taking care of the people who can feed into it. So I think that's sort of a huge aspect of it. I know Sammy also mentioned that nursing homes aren't as popular there. And sort of that goes into it, is that costs like that, while covered, aren't really super used. And so that sort of helps divert where the money is going to, because if you're not having a lot of people in nursing homes, because usually people will stay with their kids, then you can focus more on, oh, let's put more money in the hospitals than in the nursing homes, because there are more people in the hospitals. And also there's not really a need to stay in the hospitals longer, because they can go straight home to their families who we know are going to take care of them and who we know are going to be proactive because they care about their like grandma or whatever person that's living with them. So I think it's sort of a lot of that of like, why weren't we doing this sooner? Because it just makes sense for everyone to be covered. And as I mentioned, having it free for those who are unemployed or didn't have income, all of that was something that they're not really actively complaining about, unless it becomes a problem where it's like, oh, this person's getting all these referrals for no reason, which again isn't really happening because of that respect for each other. I think that we don't really see as much here.
Thank you, Maria. So there's a couple more questions, and then I'd like to hear from John a little bit, John Santa a little bit, but we have Hank and Jeannie first.
Howdy, thanks again. Excellent presentation. Loved your setup for it. In a sense, I think it addresses some of the questions that we face as state-based. Is there enough finances with 1 million population to pull it off? And does 1 million people have the administrative heft to pull it off? And I think this starts to address that. Yes, 1 million people, if the provinces in Canada are 500,000 to 1 million people at their smallest, and they can do it, why can't Cyprus and why can't the United States? The other things I'd like to hear is the transitional process, because we have a hard time explaining, so what is the transitional process going to be? What is that first year, 2 years going to be like as everybody stumbles over the new system? So it's interesting to hear further as to whether or not Cyprus is able to continue on their transition process. And also I'd like to hear again the political process to get it implemented, to get it even to approach it. It sounds like there's a little bit of desperation, and since Cyprus has exposure to European systems, they were able to look across their pond, so to be, and say, oh, why can't we be like Denmark? Or why can't we be like the UK? You mentioned there's some connection between Cyprus and Denmark as far as culture, so they experienced it elsewhere. And in the United States, where I think we're still too individualistic or separate but equal, is something we had in our history and still kind of work through. And sounds like Cyprus has more of a unified family situation. But excellent presentation again. So projects in the future, how does the transition continue to work? And what was the political process to even get it started? Thank you.
Right. So I think the political process, I'll start with that first, because from my understanding is that the government was already in place. And then they say, okay, we're going to try this rollout system. So I don't know for sure how, like, if they used it as a political scheme originally, and I don't think they did. As far as I know, we didn't hear anything of ESC until it was 2017, and it was like, okay, now we're doing this. Everyone's on board. You don't have a choice type of thing, which in the end helped them because they were having, again, all of those negative sort of, oh, this government's useless. They're not really doing anything, like they're lazy, and they had sort of that stigma. And so I think that helped them going into the new election. But prior to that, it didn't really help them get their spot in the government, if that makes sense. So it's sort of helping them maintain it because they were like, well, you had all of this, but look, we gave you this amazing system and now it's working and now it's amazing. But before that, there wasn't really any, oh, like choose us because of this, there wasn't. And I think, again, there was a lot of unhappiness with the system before because it was sort of that unfair aspect of you can't control sometimes if you're employed or not. And usually the only form of insurance was through your jobs. They had, again, private insurances, but it was expensive. And it was more like, why would you pay that if you can just get a job and have your job pay it? So I think that, and then in terms of the European influence, they have a lot of that just because of proximity, but also Cyprus is Commonwealth. So they have a lot of British aspects. They used to be a British territory and now they're still a Commonwealth nation. So they have a lot of ties to the British, which is probably why they modeled it after the NHS, because they saw that's what they saw most. And that's, a system that they wanted to follow through with. So I guess that answers the political question, I hope. And then I'm so sorry, do you mind repeating the first one?
Continuing transition, how to explain the transition process, what lessons to learn and what to expect, and how to expect Fox News to pick on every single niggling problem that is inevitable with any transition of this particular system or change.
Right. I think actually how they did the transition, as much as people complained about it before it came out, probably was a relatively good strategy because they kept a lot under the covers. So they didn't really release a lot except that small pamphlet that they referred to and that I mentioned on how it would work and the percentage and whatever. But even that was hard for people to understand. A lot of it was, we're implementing this new system, get ready for it for 2 years. So they passed the law in 2017. They were working all the kinks out for those 2 years before they launched the first part in 2019. And once it hit in 2019, a lot of doctors were like, wow, this isn't as bad. And then a lot of patients were like, wow, this is great. Like €1 copays, like, what is this? So I think sort of keeping a lot of the details out of it, which I know might be hard in a bigger country like the US, which is probably why it would be better for a state-by-state basis, also given the size of Cyprus. But I think keeping it under the covers for a little bit helped that sort of everyone got all of their complaints in and all of their complaints were assuaged. So once the system came out, they were like, oh, what do we nitpick on now? And they nitpicked on a couple of things, but all of this is like, we know that's an issue. They recognize that, yes, the hospitals are somewhat inefficient and need to be fixed. They recognize that, oh, we need to fix the compensation of the doctors and we're working on it. They recognize that, what else? Like I mentioned the hospitals, the doctors, and then there was one other thing that the waiting times. They were like, we recognize that and we'll let you see any doctor. We know that's an issue. And so they're sort of trying to keep, and I guess if you look in the law, they say it's the general healthcare system amending law. And so they've made it obvious that they are wanting to change it and that they know that that admin costs are high right now, but that's one of the things we want to lower. We know that the electronic healthcare records was a mess, so we're fixing that. So I think there's a lot that people didn't expect to come along with ESC that ended up coming along just because they didn't talk about it until it actually came out. And now retrospectively, they're still fixing it. They're still changing it and adding things or changing the compensation so that they're trying to make it the most efficient. And I think that's the biggest thing to pick up on is it's not going to be we roll it out 1 year and then you're done and it stays that way. And I think that's sort of, in my opinion, what failed or what could have gone better with the Affordable Care Act was that we can't just drop this and leave it. If we're dropping it, we need to keep working on it and we need to keep fixing it and making it for the people and for the patients.
Thank you.
Jeannie?
Thank you. I have 2 questions. Are nursing home costs covered? And the second question is, what percentage of an individual's income is taxed to cover their health care?
So for nursing care, it is covered, but it's rarely used. So it's one of those where it's covered and some money is put aside for it, but it's more so we're covering it if you need it, but most times you won't need it. Mainly in nursing homes, the only patients you'll see are patients with really debilitating diseases or conditions And even then, it's more common for them to get a nanny or like some sort of person to stay in home so that the person's still comfortable rather than send them off to a nursing home. Most times what they say is nursing homes is sort of, it's how we see it, sort of our equivalent of hospice is that once you send someone to a nursing home, they're expected to pass pretty soon after. And again, in how the Cypriot social system works is like, you want to be with your loved ones. You don't want them to pass in a nursing home. You want them to pass in your home with you and you're taking care of them. Or you have someone taking care of them, but they're still comfortable in their home. So yeah, nursing homes are covered, but they're very rarely used and they're only used in extreme cases. And then you mentioned, what was the second question you mentioned?
What percent of an individual's income is taxed to cover their health care if they are eligible to be taxed? I understand some people are not taxed at all, like students, but of the people who are taxed, what percentage of their income?
So let me reshare this screen over here on how it's financed. So employees and employers both pay into it. So right now it's 2.65% on their salaries, but you see if people are like income earners, so like they rent out property or they just have sitting money, they're being taxed on that as well. So that sort of prevents those tax breaks for people who have high incomes or people who are like billionaires or millionaires. Not that Cyprus has a lot of billionaires or millionaires, but in that case of if they're just sitting there and they're not actively working, but they have passive income, it still catches that. And you see, as I mentioned here, that they did the first phase for primary care and then they increased it for secondary and tertiary care, which going back to the implementation question, I think was really easy because it wasn't as hard of a blow as like, oh, if you're self-employed, that's a 4% tax. It's, oh, well, you ease you into it first 2.5, and then you move to the 4%. And again, another huge thing that I think is that argument of, oh, older people don't pay for anything. Well, pensioners are also taxed on it. So even if you give the money just to take it back, I think having it written out that pensioners are still being taxed on it really helps those comments of they're not paying for their own health care. But it is a relatively small percent compared to what you would expect some people to be paying for their actual medication and their actual coverage. And I think part of that is because there's not as much, I would say, greed and not as much I guess need to pull out money. People who go into doctors or want to become doctors in Cyprus usually do it because they want to help people and want to be doctors. They don't really go into it seeing the money. And as I mentioned, a lot of doctors studied in the US or the UK where it is expensive, and then came back to Cyprus to practice. So even those, I applaud those doctors the most are the ones who studied in the US and then went back to Cyprus, just because they knew from the start that they weren't getting as much out of it as they could, but they knew that that's what they wanted to do. That's where they wanted to stay. And that's the population that they wanted to help, was that they grew up with.
Thank you so much, Maria. So, John, I'm wondering if you could speak for a couple minutes about what we can learn from the experience that they have had in Cyprus.
Sure, and I'll be brief here because incredible presentation, great questions. For me, it's all about the last slide. Can you imagine an American healthcare transformation that would result in 82% of American citizens being happy and only 3 doctors leaving? That says it all. Now, that I suspect is in part a reflection, as was said before, of how bad these folks had it. But a lesson for us is, it could get that bad here in the United States. There's nothing like a good crisis to solve a problem. And these folks realized they had a very bad system and a real crisis. And to their credit, they stepped in and, for the most part, solved it. And probably, I've got to admit, biased a bit by American numbers, that 82% conforms, I suspect the 18% who aren't very happy are the higher income people. And they're paying the taxes. But imagine what they've accomplished is an incredible transfer, if you will, of wealth from the wealthier folks to the poorer folks, from the workers to the elderly. While the elderly are paying some taxes, that's an important point. I can tell you, given the incidence and seriousness of their health problems, that 1.75% isn't coming anywhere close to covering their expenses. And so this is a good example of some folks who saw an opportunity to solve their problem and did so. And congratulations. And my guess is they now have permission, given those kinds of results, to keep tweaking it. And I hope they do. So incredible, lots of lessons there. Thanks for presenting this.
Thank you. So I don't have I mean, to me, it feels like we have a crisis in the United States. So how much worse was it in Cyprus before they switched over?
So I showed in that first slide, but it was pretty bad. They, again, because it's a smaller country, people sort of saw it as, oh, well, it's just like a second world country. Like, that's why it's so bad. But it was really just because it was jobs and your private insurance, and that was it. So the healthcare costs were pretty high. They were 5 to 6% of the GDP, but really they had the highest out-of-pocket costs in the EU. They were the only EU country to not have some sort of national healthcare. And so to not have any at all and go to this like huge all-incorporating system was crazy. But also I think it sort of gave them that like kick in the butt that they needed, that, oh, we can do this and we can make it really good and we can make it work. But it was really bad. It was mainly, I think a lot of people were struggling with if you don't have a job, you have to be shelling out a lot of private insurance. And sometimes even if you do have a job, but you travel a lot, or you have a person in the family who is a student, which is the case in my family, they were still paying private insurance on top of the job insurance because they wanted to be covered, wherever they went. So it was pretty pricey. And I think a lot of times because people see it as, I mean, for my cousin, at first he hated it because he saw, oh, I had free insurance, which was on his parents, to now my paychecks are getting cut. But realistically, it wasn't that way. Realistically, he's actually paying less. And I've made that argument with him, and I got him to like actually see that he is paying less now with getting the cuts out of his wage than actually having to pay for those, and for his job having to pay for it, and for having to pay for the private insurance.
I guess the big thing of it is the fact that they have these neighbors right next to them. So like they're comparing themselves to the other EU countries, and we're not comparing ourselves to lots of countries all around us. Mexico is not someone we need to compare ourselves to for healthcare, and Canada is only one country. You can say, oh, well, that's Canada, but they're surrounded by all these other EU countries.
And I think it helps a lot. Like I mentioned, Cyprus and UK have a really strong tie. But especially that most Cypriots go to the EU, go to like the UK to study, or somewhere else in the EU, and then come back to Cyprus. So they're sort of getting that shock of like, wait, I was like, the NHS works great over there. Why don't we have that,
Okay.
But
yeah.
Betty, this is John. Notice that this doesn't include the Turkish Cypriots.
Right.
Do the Turkish Cypriots have their own insurance, or are they, in a terrible system?
So I don't know how the Turkish Cypriots work. Again, just because that's not really used by my family. We're of refugee status, so I don't really know. I would assume that they follow whatever Turkey has, because the Northern Cyprus isn't really seen as its own country by any other country. So I'm assuming that they would be going off of Turkey instead of off of their own Northern Cyprus. I might be wrong on that, but that would be my guess. And Lynn, you had a question?
Actually, that was my question.
Okay.
So do the people on the Turkish side, do they ever come to your side and ask for care?
No. And if I'm being honest, so the relations are very bad between Turkey and Cyprus and between the northern part and the southern part. So basically, if you have a Turkish passport, you are very unlikely to ever cross the border into the Cypriot side, and same with the Cypriots crossing into the Turkish side, because of that cultural just animosity for each other, and the animosity that's just going on in general between the two countries have a lot of tension. So even if a Turk would somehow like get through to the border and then somehow not be like mauled by people that are surrounding, it's very likely that doctors would not want to give them care, or that they would even want to see a Cypriot doctor, because there's a huge lack of trust again. So there's not really a point of going across.
I would have to say that if you told the Greek Cypriots that they had to pay for the Turkish Cypriots, you would have never had this healthcare program.
Yeah.
And you would have never flown, and they would have never done it. That's how bad it is.
It's very bad. My cousin was in the Cypriot army, and the Turks across the like little zone of the DMZ for Cyprus was like they were tossing rocks at all the soldiers just like standing guard. So it's very, again, you would probably only walk 1 or 2 feet before something happens to you. And then Mike, you had another question.
Yes, it seems that the €1 payment copay wouldn't cover the cost of processing that amount of money. Was that more of a political decision, knowing that it's probably going to cost more to gather that €1 than to not?
I'm not entirely sure. Usually how they do the co-payments, from what I've seen with the doctors I shadowed, was they just give they'll just give like the coin. But my guess, I'll look more into this and I can get back to you, but my guess on that is that it's a cultural thing, that it's sort of like you don't want to go see the doctor and give him absolutely nothing, so we give them something, but also the system ensures that the doctors are being taken care of still. But I think it's more sort of like I don't know, there's a word in Greek for it that's sort of like you would be ashamed to go and not bring anything or not pay anything, but it's sort of like a word that has more weight than just ashamed.
Yeah,
But
I can't remember it either, but it's like you
like,
don't go to anybody's house or anywhere with your hands
yeah.
swinging.
Do you
It's
speak?
just you just don't. I just
Do you
a
speak
little
Greek?
bit.
Okay,
A
I was
little
going
bit.
to say
So I just
there's
gonna say
like
there
you
is
would
a word.
to
Yeah.
go and see
Yeah.
and
Yeah,
not bring
exactly.
anything. Yeah,
Yeah.
Thank you. That answered
of
my
course.
question.
Well, thank you, Maria.
Mm-hmm.
Great job with having more information in your pocket here for all our questions. So there's a lot of different questions that we might have asking about, like, what are the barriers for state? Like, so this country did it, but they have their own federal government and they can make their decisions. And for a state to do it, we have these issues around Medicare and the VA and IHS. And there and ERISA, so we have these federal barriers here. It would be good to have a conversation trying to like hit at the various barriers and look at like, so Cyprus implemented this in stages. And I know in Vermont, we've had conversations and had legislation proposed that hasn't gone anywhere, but proposed to, I think maybe 15 years ago, it was like, oh, let's do all the hospitalization first. And then there was concern that, well, what if people who just need primary care go to the ER because it's free there, and that's an expensive way to take care of things. That bill didn't pass. And now, for the last 5 or so years, probably longer than that, there has been a bill about doing just primary care. The pros and cons of trying to do it stages versus just doing it. When we got Medicare, we did it in 6 months or something. It was implemented on January 1 and we signed it at the end of July or something. So, we know that it can be done. That was before they had computers. We know that it can be done to implement something quickly. But all those, another factor is the finances, the campaign finance reform that we really need. I don't know, how strong were the insurance companies and the pharmaceutical companies in Cyprus that would be, not wanting to have this happen. I don't know. And I don't know whether you have that information either about how strong those were.
So like, sorry, do you mind like focusing in a little bit? So on the pharmaceuticals, do you mean in terms of
Lobbyists
like
paying,
the
paying
okay.
campaign contributions to legislators, and and candidates for office and stuff.
Yeah, so I think again that's something that I see very much in the US. That's not really something I would say in most of Europe. I I don't know exactly any like stats or anything on it, but based on what I've seen, a lot of things are like more over the counter than what you would expect, and the pharmacists sort of act as another, I want to say another doctor without saying like another doctor, in the terms of you can go to the pharmacist and say, she's throwing up nonstop, like this hasn't worked, and the pharmacist will be like, oh, go get this metoclopramide, and like we'll hand it to you, and sort of that they help diagnose what medicine to get. And so a lot of things are, even if they're name brand and not technically generic, they're still treated generically, and only in the exception of extreme cases where we see, like we talked about the difference in copays where one medication is more, you just pay the difference. I don't really see that as much. So I don't think there's, again, just as much of a money scheme, because they see healthcare as healthcare instead of healthcare as a funding of, as like a funding
Commodity.
for, yeah, like as a commodity basically. So yeah, I don't see it much. I haven't heard of it. That's not to say it doesn't happen, but from what I would imagine, I don't see it being a huge point. And I think a lot of times, because Cyprus is so small and like he said, she said type of country, if that were to happen, I think it would come out pretty quickly and it would quickly turn people off of a certain candidate.
Thank you. You have a couple hands up here. Has Jeffrey asked any questions before?
I don't think Jeffrey's asked anything yet. So let's start with him.
Holistic, preventative care. I will say mostly, should we say, the Asian type of acupuncture and other treatments. How is that treated in this system?
So what I believe is acupuncture, again, I would have to double check on this. I believe acupuncture is included, but things such as like massage therapy, I don't think are. And then some, usually what you'll see is like a naturopathic doctor, such as like a massage therapist or something, will sort of dip into acupuncture and like will do a bunch of other things, and they'll get their training elsewhere. So that usually isn't covered in the healthcare system. But yeah, a lot of naturopathic I don't think is, but it's also not as common because the naturopathic is usually what you would just do at home from your grandma, and then you go to the doctor when you have like a problem with that. So it's not a huge, you'll see every now and then a massage therapist who also offers acupuncture, but it's not like you would go to someone specifically who is an acupuncture unless it's like a doctor for nerve pain or a doctor for something else, if that makes sense. Did that answer your question, Jeffrey?
You did a great answer through there. I didn't ask you about chiropractics.
Okay. And then, oh, so did you, for chiropractics, I think it would go along the same lines. I'm not entirely sure just because it's not as common. But yeah, as Betty said in the chat, there's a lot of of like your grandma passed it down from her grandma who passed it down from hers type of treatments. But I can double check if you want to drop your email in chat and then get back to you on it. And then Michael, you had another question?
Oops, sorry. Yes, I have another question, right? Given your time that you saddled with the Cyprus doctors, right?
Mhm.
And observing people's experience regarding the Cyprus healthcare system. My question I want to ask is, given the political circumstances there in Cyprus versus America, did you ever notice like any? I'm sorry, it's about the pharmacist. So I'm just curious about the pharmacy in Cyprus. So given the fact Cyprus had transitioned to a new healthcare financing system, did you notice like any like drug formulary restrictions on what patients can take, even though it's funded through general taxation?
I think at the beginning there were some issues because of, how the rollout came out and they weren't really sure what was going to be covered on the formulary. And I think that was another one of their concerns, was what would be covered and what isn't. From what I've heard is that people have been surprised because it's covered a lot beyond what they expected. So I think it's a lot of like, if you have some sort of rare disease, such as that person who was talking about the autoimmune disease, and like the patient is on a medicine that you haven't really heard of or you don't really see commonly given, what would happen? Most times I've seen them covered. I don't think I've seen a case where it hasn't been covered. Not to say that they won't. Again, the only thing that I've seen has been where you have to pay the difference in the copay or the payments of two medications. But it seems like if it is one type of medication, for the most part, it's covered. I can double check on their formularies and see. But that's from my understanding, that they covered some like obscure things that people weren't expecting. Because again, usually also another issue is that or another benefit to Cyprus, but like issue in the US, is that Cyprus isn't as over medicated. And so usually doctors won't have patients take medications if they think it's something that they can fight off or like be fine on by themselves. So that's another thing that I think plays a role in it, is that they'll cover it because they know that the doctor wouldn't prescribe it just for the heck of it.
Right. And how do you see the transition of like our country being like over, like once we implement Medicare for all, how do you think we should phase out like the over medication, where it does become like like with the fentanyl crisis?
I think that's going to be one of the hardest things. I'm not the best on figuring out how to do that, unfortunately. I mean, I work in the pharmacy, so I do see a lot of the pharmaceutical side from the US, but I honestly think it's going to be a big fight, because a lot of the doctors I've shadowed, even their patients will be like, can you also prescribe this and this and this? And so it's like, yeah, it's suitable for this, condition that you have or whatever. Is it necessary? No. You could technically fight it without trying an antibacterial or an antibiotic first. But is the patient going to want to come and spend 2 visits? Probably not. And especially if they have a copayment that's expensive for their 2 visits, they'll only want to get 1 visit and get all their meds for the year or all their meds for whatever in that 1 visit, which I think also comes down to maybe not being as scared of going to the doctor and being hit with a bill would make people not be as scared to like be without medications, if that makes sense. Because if they needed it, they could actually go back instead of being like, oh, maybe I'll ask for amoxicillin now just in case I need it later, which I've unfortunately seen in the US system. And then just to answer the question in chat real quick, vision care and dental are also both covered. So that's another benefit of it. It's really all encompassing. I believe those will go under secondary because technically it's preventative, but I would have to double check on that. But they are covered. I believe they came out in the second rollout of ESC. And then Ellen, did you have a question?
Yeah, I was really struck during this conversation about the comparisons between Cyprus and the United States, the differences between the corporate intrusion in our elections and our governing process, and also the cultural differences among the people. And there's another one, which here in this country, distrust of government has been heavily fostered and absorbed by much of the public. And I was wondering if that exists in Cyprus, or it was an issue at all in accepting the new system.
That was a huge thing. And I think it was very much emphasized by the fact that they were very spare with what information they gave about the system. As I've mentioned a couple times, the government was not really, they were just thought of as lazy. There wasn't trust that they would get anything done or that they would fix anything, because that's what the trend was that they sort of just sit back. They didn't do anything about there was a part when Turkey tried getting into the Cypriot government and they didn't really do anything about that. They like kind of pushed back a little bit, but they were like, it was mainly the people who were fighting back against it, not really the government. So small things like that where they were just seen as lazy. And I think the Cypriot people were very, I would say, like somewhat unhappy with the government before that happened. And then once they saw the system, they were like, wow, so you're taking more money from us, but again, you're not going to do anything. You're just going to sit there and waste it. Like, you're going to have all these high like costs, and then you're going to take all of our money, and we're still going to need insurance besides that, because no doctor is going to enroll in your stupid plan. Like, this is just stupid, you know? And so I think there was a huge distrust, and there was a lot of skepticism that it won't work. So I think that's sort of where it came through really well that it did. And I think that's one of those things that you can only at some point prove it wrong by doing it right. And I think they did a really good job of showing that. And I think that unfortunately might be where we have to be, is that we just have to do it and just go through with it. And then people will see afterwards, you know, this was a really good change. And, you know, we were all skeptical, but it did work out. So.
Oh, and did you answer the question? I think somebody did say, who was the genius behind this, or how did it get passed?
I'll need to look up the exact name of the person.
Was
I
it
can drop
somebody
it
in
in.
Taiwan had a team of people actually from a couple of different countries. So I'm not sure which person.
Oh, that's true. Yeah, you did say it was the team that had designed the Taiwanese system. That
Yeah, let
okay,
me,
got it.
I can try and see if I can find an actual name of the person. But yeah, I
That's
know it
okay,
was one of the
yeah.
people involved in the
Mhm.
Taiwanese project as well.